So we are moving on to the next session. It's going to be another panel on medical legal challenges in modern healthcare.
So good evening. I thank the organizers of DAISICON for this wonderful opportunity. So quickly going into the session. So we have a senior legal counsel and a litigator and a hospital administrator who is also an NABH assessor with extensive experience in handling medical legal cases.
Hello.
So quickly going into the session, I am going to take up certain controversial issues or the burning issues in healthcare, especially pertaining to OP practice. So now we know that giving a generic prescription has almost become like a compulsory, and most of us use a software where the generic form of the drug is mentioned along with the brand name. Though the brand it's under our choice, the generic has to be mentioned, and it has almost become like compulsory that the generic needs to be mentioned, and the patient has the choice to go to any pharma to buy any brand of their choice, or even you can go to the PM Care pharmacy where the absolute generic can be taken in at almost 20% or 30% of the price. So this becomes a kind of controversy. And also we know that a major chain of pharmacy always has the habit of changing the brand without even telling us. All of you know what I am talking about, which chain of pharmacy. You go there, they will definitely change and they will say, we have our own brand which is 30% of the total cost, and they will substitute without even we knowing. So in this context, is it mandatory to mention generic name of the drugs? Is the pharma brand interchangeable with the generic form without informing the physician and patient? So what's your take on that?
Sir, generic name must be mentioned. Pharma interchangeable with generic form, I think it is allowed by the dispensing pharmacist, and it is not legally invalid for them to issue something else. But without informing the physician is something that needs to be done, because if they are going to change some prescription, they are legally bound to actually inform the physician.
So by law, they cannot do that without informing the patient. They have to say that if they are changing the drug, then this is the substitution or this is the generic form that I am giving. This has to be mentioned to the patient. And without informing the physician, as long as the formulation, the generic formulation is exact, the patient need not go back to the physician to get it changed. But if the pharmacist is suggesting his own formulation or saying instead of taking one drug with all these three drugs, why don't you try these two drugs which will give you the same thing, that cannot be done. That becomes an issue in healthcare.
So if it is the exact formulation, yes, the pharmacy has legally it's right to substitute. Yes. That's what you mean.
After informing the patient. And if the patient insists on the brand name drug and they don't have it, then they have to say we don't have it. They cannot say this and this are the same.
There is something very interesting also. Recently there's an amendment in the medical code. Before 2016, the code said that you have to only prescribe using generic names. But in 2016, there has been an amendment in the NMC guidelines that says that it is not mandatory, but you are preferred to actually use a generic name. So even if you're going to write a brand name, it is fine, but you have to also give a generic equivalent to that. So now the government has also, to promote the PM, the generic medicine, they have tabled a new amendment for the Drug and Cosmetic Act. So that says that now there is no the Drug Substitution Act is not present in India. Drug substitution is something that a pharmacist can actually do based on the prescription. That is not actually legally valid in India till now. But now the government is actually planning on doing it legally, making an amendment to the Drug Cosmetic Act, because they want to promote the generic medicines in the PM dispensing.
So I believe, when I go to a department store, when I ask for a toothpaste, they can give me choices. This paste is 10 rupees, this is 30 rupees, this is 70 rupees. So I have the choice to choose the cheapest one. Like that, I believe even the pharmacy can even quote the price of the drugs, and the patient has the right to choose the cheapest one. Am I right with that?
Yes, they can, provided that they know what are the drugs available and what are the combinations.
So the take home, we cannot, as practitioners, we cannot crib with the fact that the pharmacy chain or any individual pharmacy is changing the brand you prescribe. That's the take home. So the patient has the right and the pharmacy is not legally wrong.
Yes.
Okay. So that's a major change now. So you have a patient here, 47 male, long-standing diabetic CAD. Patient develops pemphigus skin lesion secondary to a drug effect, probably gliptins. Patient takes a physician takes a photo of the skin lesion without written permission. Is it permissible? He may share in a journal, or he may share just in a WhatsApp group, friendly WhatsApp group. All this can happen. So how do you view this? Even with de-identifying the data, I'm not going to tell the patient's name or the identity. Even then, how do you legally see this when I share in a group or in a journal or whatever?
Okay. Definitely it is not right. You have to inform the patient before you take the picture, and you have to ask them. It is not merely that I am taking a picture now. You have to actually say, this is a picture, or this is a lesion on which I would require some other pair of eyes to look at it, second opinion or whatever. Can I take a picture? And if the patient says no, then it's over. And merely de-identifying the data is not enough, because the consent has to be given at the first point. You cannot secretly take the picture. So taking the picture is the first effect, and then comes the matter of de-identifying.
As Madam rightly said, consent should be the initial point. Yes. We have to actually declare that we are using your photograph for any purpose. It could be academic purpose, or for your own sharing, or for your professional opinion also. But we should also understand that that particular consent could be withdrawn by the patient at any given point in time. So he has the ultimate autonomy to decide whether he wants to make you still use the picture, or he can also withdraw his consent any point in time. So that is also something that we need to take into account before we get the consent.
Correct. And you have asked the second question, is consent written consent mandatory? Not if you are not planning to publish. If it is going to be published, then publication guidelines and ethics now say that you have to have written consent, or for any other research purpose you need written consent. But otherwise, written consent is not strictly mandatory.
So when it comes to intellectual property right for the patient data, which includes patient's case sheets. So I keep telling this, we conducted a full day medical legal conference in Vijaya, where I mentioned this incident. Years before, when I was rounding in the ICU, I saw a gentleman, I was walking into the ICU, a gentleman was an attendant, was seeing at the case sheets of the patient. I told him, sir, please don't look at the case sheets, sir, you cannot look at the case sheets. He asked why I should not look at the case sheet. No, this is hospital data. Anything you can talk to me or the doctor. He said, no, the case sheets belong to the patient, not you. I didn't know how to answer. So, no, sir, this is hospital case sheet. No, I am a lawyer. The case sheet belongs to the patient, not to the hospital. You are just a custodian of the case sheet. So I didn't know how to answer that. I just walked away. So in this context, later I learned that the case sheet belongs to the patient, not the hospital. How do you view that? Do you think we own the case sheet?
No.
I mean, hospitals own the case sheet, or who owns the case sheet?
The case sheet is a property of the patient. So if a patient is going to ask you his indoor case papers or OP case papers, we are bound to produce the same in 72 hours. That is the regulation. So we cannot say that I hold your thing, I hold your records, and it's not for you and all. The ultimate onus, we are only the custodians of the case sheet and the records. So now, as we are going digital, the government has also brought in this the system of Ayushman Bharat Digital Health Mission, where everybody's record is going to be. But for a practitioner to access a particular patient's record, you need his Aadhaar OTP authentication. Only then you will be able to get, which itself means that he is the owner of the record. So we are talking about the physical forms even now, but once we go digital, I think everything is very clear.
Yes. In fact, one more aspect there is that when you are digitizing the record, the patient should know. Okay. The patient should be informed that e-records are being maintained of it.
Okay. So you have to take a separate consent for that.
In that documentation, you have to mention that the document may be stored as e-record.
Okay. So this is a diametrically different perspective which has happened in the last, 4 or 5 years probably. The patient family can request the Xerox of the entire case sheet, you have to give. If they place a written request, I want the Xerox of the entire case sheet, you have to give. We cannot say, no, I will give only summary. Those things are, I think, going away, and they have access to the full case sheet. That's something we need to know. So it goes without saying that we have to be very proper with our documentation, because they have access to the internal details.
Yeah.
Probably yes.
Yes, sir, because the case sheet itself, it is about a person, no, sir. I can go to a government hospital, I can go to a private hospital. It is based on my paying capacity. But ethically and legally, That is my data that you are holding. It could be government or private setup. But maybe the intensity, the gravity of the situation is different in both institutions. But it is the same.
You have to give the original case sheet.
No.
Or give the Xerox copy.
If they request, no, you have the custodian, so you cannot give a original to him, because later stages someone else may also come and ask you the same case sheet. So you are a custodian. You can only give a Xerox that is within 72 hours.
Some patient is died. Due to some procedure, some patient died. Some relatives are sick. From whom you have the case sheet?
The LAR, the person who is the legal heir of that person or the designated proxy of that person.
The advocate asks for case sheet. Without any court verdict.
Sorry?
No.
Without any court verdict. Without
Yes.
any court directions. I'm the patient advocate. I need it for original.
No, no,
You
no.
cannot.
You can ask. You can give or not.
No. Unless they have some power agent.
So this frequently I have faced this. There are a lot, sorry madam, but there are a lot of advocates who walk into my office and ask for a case sheet. Point blank I say, no, I cannot. Do you have a directive from the court?
Correct.
If he says, no, I don't have a directive, are you related to the patient? If there is no to both the questions, I directly said, then I cannot do. See, you being, sorry madam, but you being a lawyer, you should know that I am just a custodian. I cannot give you the paper. This has happened to me a couple of times and I have successfully told that I cannot give the case sheet. And they have walked out peacefully. The only problem comes is when we don't know what to do and then they make use of the situation. Not only in this particular case, but in wherever, if we know what we are supposed to do, I think we can stand our ground.
The same situation happens to lawyers' records also, sir. We also cannot give the record to anybody who walks in and says, give me the record. That also belongs only to the client.
I don't have.
You can come to them.
Mic is there, somebody?
Oh, you mentioned about the case sheet, because in a hospital there are many records, nurses maintain IO chart, diet chart, so many other charts. So all those things also, every record is responsible. No, normally in the case sheet, the doctor notes are predominantly written and the prescriptions and procedures are written. Other notes, for example, IO charts and other supporting documents are usually maintained separately. So when you say who owns the records, including those also,
Yes. That's right. Observation.
See, that's why, for example, NABH comes with a guideline, what are all the charts to be kept with the patient records, which include nursing records, dietitian chart, IO charts, fever charts, everything will be there. As per, for example, I'm just quoting NABH because that's quite popular. Whatever the charts approved by NABH, for example, they are the property of the patients. So the patient's family has the access to that. That's how we have to see that.
You're
I
right.
think the legal hair should be a right word. Sir.
The legal heir or the legally appointed representative is the only person who can be given the record in the case of the deceased person.
I just want to share one small thing. There was one case when one person had two wives. Both are legally wedded wife. Now the second wife had admitted him. She got the case sheet, discharged somebody and went off. Now the first wife had come and again asked for the case sheet. And then we were not able to do anything because both of them are legally wedded wives. So this is a scenario where we need to retain the case sheet because I need to give the case sheet to both the wives. So I think this answers your question.
So coming back to that presentation, see, this news came 2 days before. I don't know how many of you saw this. This came in the media. It was popular in the social media. Happened in California, where a group of urgent care workers, where doctors were there, nurses, paramedics were fired because they were taking photographs of patient samples, not the patient. Patient samples spilling on the mattress. All this they were making fun. No patient identity is exposed here. These were the photos which came in the TikTok and they were fired 2 days before. Make sure, because in our setup still the awareness is quite less among the patients, luckily for us. But the awareness is growing and some patients learn that, the confidentiality is an issue. So we need to be careful about while sharing the patient data. So going to the next vignette, 22 female, brittle type 1 diabetes, where you arrange free insulin through a camp with some community support like a Rotary or any Lions Club and all that, and you provide a free CGM monitoring with pure intentions, absolutely pure intention. Patient finds that insulin is beyond its expiry date and sediments on standing. CGM device malfunction, admitted to DKA with the hospital. In this context, does the court of law see does it have a different view when it comes to free treatment or free medicines, or are you going to sue us or punish us irrespective of whether it is freely given or not?
Irrespective of whether it is free or not, it is malpractice. It is the service of medicine is provided, that's all. Whether it was provided free of cost or not is irrelevant, and the medicine and the device were provided as part of that treatment. So therefore it is malpractice.
To add to what ma'am said, so there is the landmark judgment everybody knows, the VP Shanta versus Union of India. That clearly states that now all even free services are included. So that's why the even you can sue a government doctor also for not providing a proper care, because the life of a patient is more important. This question I see it in two ways, sir. One is a therapeutic misadventure that is going to happen when we are doing something. Of course, if there is a good paperwork and a good legal background, maybe you can come out of it. But in practicality, if there is going to something is going to happen on when you are treating the patient, the chaos that we need to face is much more damaging to the profession per se. So we should take extra care when we are prescribing such things.
Yes, exactly. For the second part of the question, if it is provided by a third party, the final liability issues can be settled between them. But the malpractice is done by the medical professional who issued the drug.
Okay, so the prior paperwork has to be proper. How they are going to divide the responsibility?
Yes.
There was one case in Maharashtra where a doctor was actually arrested because he was actually conducting the sterilization camp. Ultimately, a few of the patients had died. But then there was no malpractice in the doctor or his procedure. But then they found out that the solution, the NS that was provided for all the procedures was a problem. But he came out eventually, but I don't think he's practicing anymore.
Yeah.
So when we are going to subscribe or we are going to prescribe such free medications, we should also put our profession in front, and we don't know what is going to happen because it is anyway supplied by the third party. So that liability is always there.
So
What I would say is, even if you are accepting, sorry for this, accepting sponsored medicines or free medicines, put it through the same strict rule which you have for medicines or devices that you will buy. So exactly the same criteria you have to apply.
NABH is very clear, sir. You cannot actually prescribe any
free medicine, sample medicine.
Free sample medicine is not for patient safety. Now we are from patient safety, we are moving into patients for patient safety. So what happens is NABH is very strict. I am sure if from institutions that are accredited, they would know that whenever there is an inspection, they will definitely make sure that all these samples are thrown away, because it cannot be found in the premise at all. So that itself clearly states that we are not supposed to, because we don't know what is there.
Even JCA is much strict than this. JCA inspection happens in institutions, not a single paper which is not approved by the JCA should be with the patient record. Everything, all the paperwork should be as per the prior intimation given to the JCA. Not a single gadget, even a glucometer should not be there, which is not part of the institution. I am a diabetologist, I cannot take my own glucometer and check in the hospital. It's not allowed. It all should be calibrated by the hospital team, professional, then only that will be included in the hospital armamentarium. So they are very strict because of these reasons. That's why JCA and NABH are quite strict about that.
We can take a few points because we are concentrating on the OP practice per se, sir. So if there is any gadget that you are bringing into your OP practice, I think it should be store bought. You should have a protocol to buy it from a very authorized vendor rather than taking the freebies and using it on patients. That we need to be very careful.
So as long as we don't get into trouble, these things go. Once we get into trouble, then all this keep rolling. Okay. So what is Clinical Establishment Act? Is it relevant? Do you really think Clinical Establishment Act is needed?
Yes,
Who
sir,
is
it
going
is.
to check? I have never seen anybody coming and checking that.
Sir, now it has become very mandatory. But
Mandatory, but is there a checkpoint?
Yes, there is a checkpoint when there is a problem. Yes. So if you have no problem, everything. So even you can go on the road without a helmet until the police doesn't catch you. So that doesn't mean we are not doing something wrong. But statutory requirement is every institution, even a small clinic or polyclinic, hospitals, accredited, non-accredited, must have a Clinical Establishment Act. This is not a state act. This is a central act. So all states have enacted their own clinical establishment, but it is mandatory. For any further services or accreditation or certifications that you require, this is one thing that is mandatory. All government agencies are asking. And it is pretty simple to apply. You can just go or do it online. Of course, there are a lot of things that nowadays everything is faceless. So
How
this
do
is-
you, from the court of law point of view, how do you view, there is a doctor who is well qualified, well experienced, practicing in a clinic for a very long time, 3 decades, but it isn't, his clinic is not registered with the CEA.
Yes.
That is known to you as a lawyer. How do you view that? Are you going to be sympathetic with him because of his experience, or are you going to be
No,
strict?
no. When it comes to self-compliance and being compliant, it does not matter whether there is experience, whether he has a bad record, good record, whether his patients have recovered, not recovered, and whether it is Consumer Act or going through consumer court or going through criminal court, they will not view it in a lenient manner.
So I like that analogy quoted by Dr. Prasanna. You may be a Ferrari F1 driver, but you don't have a 4-wheeler license in India or caught in the signal. That means you have committed a crime. You cannot say I have driven car for 40 years. Doesn't make sense in front of the law. So Clinical Establishment Law Act is compulsory. Please do it.
One thing I just want to add, sir, the 2 things that we are all missing. One is an expired license we are not renewing. That is also a problem. The other one is if there is a address change, you need to reapply. This not many of them are following. They say I have an old TNCA, but it's not valid because your current practice must have a valid license.
Yes, and if you're changing your hospital or you're changing your location, or even if municipality changes your address, at the next renewal you have to change. You have to renew it.
So it's becoming more and more difficult for the practitioners to be up to date with the law. So what are the qualifications which can be mentioned in the clinic boards and prescription? For example, if I have an American board certification, which I think is, I have gone to US, I have taken a degree and all that, but that is not registrable with the NMC, National Medical Council. How do the law view that?
So it cannot be put up on our boards, and it cannot be mentioned as a qualification in our letterhead or wherever the patient or the registration bodies are looking at it. They should not get confused what is this registration. At the bottom, you can put at the bottom of the letterhead or in some promotional material or in some brochure or something, you can put it saying that I have an additional qualification from some US or European agency. But it cannot be treated as a qualification unless it is registrable with the NMC.
So the the 2 documents which are important in this context include prescription and case sheets, where this extra qualification should not come.
Should not be
It can
mentioned.
come in free
Promotions.
pamphlets and promotional things, which is not
Yes.
going to be a problem.
Yes.
So
I have a question. I applied for Clinical Establishment Act, approved, 5 years over, applied for renewal. Renewal inspection happened. There was some corrections. I uploaded the correction. They not yet issued me the CEA certificate. In this time, I encountered any problem, will I be liable for
No,
that?
sir, you have a copy of your application, no, sir? That's enough because the ball is not in your court; it is in the government's court. So you have applied, so you are safe. If you don't have any application, then it is a problem.
Sir. Yes, sir, exactly. Now we call it NMC. Only NMC registrable degrees should be in the board, or in the pad, or in the case sheet. No. Sir asked whether NMC registered qualification only that should be mentioned in the board, or other qualification can be mentioned. No, only the qualification registered with the NMC can be in the board, or in the prescription, or in the case sheets. Anything, sir? Yeah.
That's right.
So this is quite, there's something which is coming up, and all of us do this. All of us have a WhatsApp, and patients keep messaging. Now also I mentioned 2-3 patients about some drugs, increase in insulin, decrease in insulin, all that. All of us do that, and that's how we practice in our country. So how are the legal liabilities different? Is it going to be different or same? How are you going to look at that? And what is your view on this digital telemedicine? Because Dr. Prasanna has extensive experience in handling the telemedicine. Let us see how.
Sir, legal liabilities is the same. So we need to get a consent, we need to examine the patient, we need to arrive at a diagnosis and then prescribe. That doesn't change. The only thing is the mode of communication is only going to change because it is going to be virtual. Other standards need to be followed. We should be very clear in this. But now, as sir said, WhatsApp, everything is fine, but as per, you can give your opinion, but if you are not able to arrive at a diagnosis, I think it is better you call the patient, have a video consult at least, or call the patient or ask them to go to a nearby doctor to get it diagnosed, where the the physician, the other physician can discuss and arrive at a diagnosis if they are in a remote place. But WhatsApp is fine, but I think sending a prescription should be to the registered email ID, and identification of both the parties, like who is getting the treatment and who is giving the treatment, should be established and clearly mentioned. So the prescription remains the same. You need to add a few more points that you've all done. These checklists needs to be there.
In addition, I would like to say that the doctor cannot delegate that task to somebody else. Suppose I am outside or a doctor is outside and there is somebody picking up the phone or WhatsApp and they are examining the patient on the phone, or they are receiving the query on the phone and that query is being communicated, and then they advise that person, okay, tell them this. That is not permissible. The person on both ends should be the same identified person. On the one end should be the patient, on the other end should be the prescribing doctor, not his nurse, not his delegate, not anybody else. Similarly, the patient's family also cannot pick up the call and ask. In which case you might have to ask, unless they
Because
are
So I can recall an
unconscious.
incident recently in Tirunelveli or somewhere where something happened.
Yes,
right?
sir. In October 23 October, there was, this also came because of the TNCE only. They only came and sealed the office because the doctor was actually not present in his clinic. He was in another hospital and he was instructing his non-medical staff to actually give injections, and they were caught red-handed. Now, it came in the news, they were sealed. There are 2, 3, even Sushant Singh Rajput, who died, an actor who died, Bollywood actor. The doctor was actually called in the court of law because he had actually given a lot of clonazepam prescriptions prior to his death. It was only because through teleconsultation. Because there are 3 classes of drugs that we can prescribe: A, B, and O. O is over the counter that we can give, like paracetamol can be freely given. A is first time prescription for asthma or something like that. B is a refill for diabetes. These things are very comfortably we can give it using teleconsultation or any other mode. But these Schedule X drugs should never be prescribed online.
For the first time.
For the first time, I think
Yeah.
even refill prescription, I'm not
Refill
sure.
prescriptions you can give if it's an urgent thing, like they're traveling or something.
Yeah.
Then but you must ensure that they are informed. They should come and meet you at the earliest.
And the day should be mentioned. Like if it
The
is for
date
5
should be
days,
mentioned,
5 days.
yes.
You should not give for 1 week, continue as long as you want. All those things should not be there.
Prasanna, are you sure WhatsApp consults are okay? Because email I am very sure, but WhatsApp.
Sir, I am in practicality
Can I
because
add?
everybody are using WhatsApp.
Can I add, Balaji? Can I add?
Yeah, please.
Yeah. This is as per the NMC guidelines. This is teleconsultation is approved by NMC during the COVID period only. Before that, we are not aware of it. During COVID, they have a clear-cut guidelines. In that guidelines, they divided into new patient and old patient. Any new patient, we have to do visual collection through WhatsApp or any mode of consultation, but you have to see the patient through video call. That is what? That is called as new consultation. The old consultation, a patient consulted you within 6 months. If the patient come back to you, that is called as old consultation. That can be done by video. Not with video, you can do with audio. But first consultation only with video. If a patient come back after 6 months, then it is considered as new consultation. Then again only by video is approved, not by audio, through audio call. And another caveat here, the problem here is, if a patient go back to US or UK or anywhere else outside the country, even though it is your patient, you cannot give prescription. That is the most important thing. So our patients goes back to any other country, we can't give a prescriptions, we can't do consultation. But as a doctor, as a medical profession, in case of emergency, you can suggest that you can reduce this dose or you can increase the dose. That dose adjustment can be done with video calling, but not by just by over phone, or you can't raise a prescription. The patient is in some other country, his passport suggests that, but you are giving prescription on this date, definitely we got into a problem. So don't do consultation, even though it is your own patients somewhere out of the country.
So I just want to add one point. Very valid what sir said. There's only one thing. If there is another rule also that says that if I want an expert opinion from a doctor who's in the UK, that can be done. But it should be a physician and physician. I cannot have
Exactly.
that. Yeah, there should be an intermediary person should also be a physician. Let's say I want an expert opinion from sir who is in the UK. I have a patient here. I can talk to sir, explain. He will make a diagnosis, and I need to transcribe it in my prescription, stating that this is the diagnosis that we have made, and I will prescribe the drugs in in consultation with him in our. In my prescription pad. So that is legally valid, because
And
that is
even
also one thing that we.
That is such a way that even in India also, if you are not able to see the patient, but if a doctor, a medical professional refer you, if a patient is inside hospital, particularly in diabetology, new consultation comes over phone. Doctor, this is a sugar, what I do. If a doctor speaks to you, you can give it definitely, you can give insulin dose. So this is a doctor take care of you. So if it doesn't mean that somebody talking about you, unless without seeing a patient, you have to see, anyway you are going to see the patient. If you are outside the state or outside the country, if you are going for a conference, you are coming here, some other person asking for about this patient, what is the dose I can give. If a doctor call to you, you can give it. And a doctor is taking care of the patient, that point you can do it.
Yes. But everything should be noted, sir.
Absolutely.
Even I should identify. The identification again comes because the other doctor on the call, I may not know who he is.
Yeah.
So his registration number, his identification is mandatory.
Yes.
Yeah, that time we can give it.
Sir, is he your employee or you are part of an institution, sir? No, it's just a question. If he is part of an institution, if there is a protocol for your institution to do such things, like I can call the consultant and ask orders through the duty medical officer, whose records are maintained by the institution, it is valid. Am I right now?
Yes. Yes. No.
No. He should.
Yes.
That he needs to
That is
write.
allowed.
Yeah.
That is
Yes.
allowed.
But
By
he can-
orders from Dr. So and so, I am prescribing these medications.
Yes, but the prescription will be signed by the duty doctor.
You
And,
cannot-
yeah,
sorry.
you asked about WhatsApp. So WhatsApp consultation is, WhatsApp communication is not considered to be valid communication in law.
Law.
So while you may do it because it is practical, if it comes to proving something, still WhatsApp is not considered to be communication. So I would say that if you are doing WhatsApp communication, follow it up with an email. Email is legal communication.
Email is illegal.
Sorry.
Yes.
We have been seeing patients from the West Bengal, Assam, Mizoram and other things, and obviously they cannot come frequently to Chennai, and the only option is our telemedicines only. And another problem is language. I do not know Bengali, I do not know Assami, and the same thing from their side, they don't know that is our language, even English. In that case, can I have a translator and she can converse with the patients and vice versa?
But your presence is mandatory, sir.
Yes,
Your
my
presence is mandatory,
there.
but you should also make a mention of who's the translator, what language are you translating in, from what time to what time is she present with you.
It should
This
be recorded.
Yes,
Yes.
it should be recorded. Because the same thing can happen for an inpatient who's coming, there is this medical tourism that is happening. The same translation problem for all consent is happening. So on a larger scale, if you see, there will always be a place that says translation required or not. Who is the translator, identification of the translator, what language did they translate.
You mean to say in all that the prescriptions of telemedicines, I should write that the name of the translator,
who is translating.
and the time and also the
Yes,
language.
exactly. And who is receiving that? That identification.
That
has
is
to-
obviously the patient and of course the translator's name. Is it mandatory by
Yes,
law?
it is.
Yes, it is.
Thank you.
So regarding a mention about Schedule X drugs, this law exists, but yeah, please.
In some platforms, second opinion senior consultants give, that is the platform itself mentions that the patient, especially with regard to oncology and all, second opinion can be obtained through our platform with senior most consultants by sending your image, biopsy report and the clinical details. Is it valid in law? Directly seeing, that is patients as a second opinion.
Yes, sir. It is valid because it is a personal choice one, and the identification of the patient, it is his own will that he is going and enrolling himself. So if you read the consent, it will be very clear that out of pure will, I am coming and getting a second consultation. There is nothing to stop because it is the same thing. The consent is got. patient has been identified, the doctor has also been identified, they can very well take a second consultation.
There is also one more thing. On such a consultation platform, they will not be treating the patient.
Yes, yes, it's only an opinion.
It's only an opinion.
Expert
so
opinion.
they will say this is an opinion based on this record. There will be lots of limitations. And then it will say you have to go to a treating physician to get this opinion
But
validated.
with this regard, I just wanted to clarify, Dr. Shanmugam said, new patient, to my remembrance, new patient cannot be entertained as per MCI through first time in WhatsApp consultation. First time the person should have been a patient for
can
the
I-
doctor. Is it, please
Sir,
clarify.
the purpose of this telecommunication during COVID is patient cannot able to come. So that is what they bring this WhatsApp telecommunication. In that case, new patient, how can they come in person? Definitely they cannot come
Can
in
we
person.
do it after COVID? Now also new
Now
consultation?
the same valid, the document is still valid.
Yes. Sir, now as we rightly mentioned, we are moving into digital platform. Now everything is going to be a single window system where everything is Aadhaar based. So it is going to the NHCH portal. Your insurance, health insurance, your payments, whatever you're going to do, everything will be based on your ABA number. ABA is Aadhaar based health record. So once that is come, then digital validity, whatever you're asking, I am authenticating my consent using my Aadhaar. So it is valid.
See, 2 points I want to add. When it comes to Schedule X drugs, the pharmacist has to put a stamp in the paper saying that, for example, lorazepam, 30 days delivered. So this law is there for a long time, but it's not being widely practiced, and pharmacists have started practicing now. Again, this has kicked up. Yeah, regarding teleconsultations, I have done teleconsultation for remote ICUs in India for 6 years, sitting in Chennai. We have done through Philips as an intermediate for technological support with the US based intermediary platform, where we have done ICU services for rural ICUs across India. I have done that for 6 years through our group, Critical Care Consultants Group, where the order will be taken only by a doctor in the hospital. I cannot talk to the patient directly. He will give me the history, he will give me the findings, I will give a solution which will be recorded by him with this register number. I want to reinforce the fact.
So I have two questions. One is, in the rural areas, the non-internal medicine people are endocrinologists practicing diabetes and hypertension. Let it be MBBS or a orthopedician or a pediatrician or a gynecologist, they are writing prescription for diabetes and hypertension. If anything happens, or they liable, they are not qualified for that particular thing, your MBBS qualification is sufficient to treat both diabetes and hypertension.
Sir, I think you can correct me if I'm wrong. I think you are talking about rural areas where healthcare itself is a big question mark. I think in that case, I think health of the patient is more important rather than the qualification of the treating physician.
So if that is a condition that by law can be, by your guidelines can be treated by a general physician, then they can. And but if it is something serious, I don't know, like neurology, stroke or something which may be not within the capacity or competency of a general physician, then he should not do.
There are villages, for example, for the next hospital or a neurologist, they have to travel 40 kilometers.
Yes.
In that case, can an MBBS doctor give the first aid in
Yes.
good intentions?
Yes.
And what
Stabilize.
is he liable if something happens during
So-
that stabilization time?
So
That's what he exactly
yes,
does.
yes. If that is the question, then he has to give the rescue medication or stabilization requirement, and he will not be held liable if he can show by documentation that these are the conditions under which this drug was prescribed. But if it is 5 minutes away, some other proper competent doctor is available and I did not do and I was giving the rescue medication, then it will not be valid. If I can
I think it's
show
called
that
the act on good faith, if I'm not wrong.
good faith.
Yeah, good faith is something that will protect you because you're doing something for the welfare of the patient.
So another situation, in a metro like Chennai, every specialty is available. You have a gynecologist treating diabetic patient, hypertension on regular basis, not on emergencies.
I don't think that is valid, especially in
And one more
Chennai.
thing.
Metros like Chennai, I think we are...
I have to refer to
Yeah,
specialist.
yes, we have
One more situation. In my hospital, orthopedic fracture happened, surgery done. The patient is unable to come to regular follow-up. Can I see the reports and prescribe the adjustment doses with when the attender comes?
This is with regard to diabetes, sir.
Diabetes. Is orthopedic intertrochanteric fracture operated, advised?
But you
for
can make
6
a
weeks?
mention of whatever the positive findings that are. Like if they are providing you with some report that you can mention. And due to this cause, I am giving a thing. And anyway, we are going to mention that you are going to review with me after so many days.
Absolutely.
So you are not going to perpetually prescribe something for it. So it should be for that set period only.
Okay, we'll go to the next, we'll complete the session and then they're running short of time also. So when it comes to professional indemnity insurance, let us make it quick. Do you think professional indemnity is well established for IP, inpatients? Do you think it's relevant for OP doctors?
Sir, I think it is mandatory for OP doctors as well, because it is a very meager amount that you are going to pay. But for facing litigation, you will have a much more coverage and leeway.
It is essential. It is good for you.
So if I change the clinic address, does it hold good or?
Yes, sir. Small print is very important, because the place of practice must be actually told to the insurance company. If you are practicing in multiple places, please ensure that all places of practice are in your
Covered by the
insurance. Please don't get this all India practice. I've seen this policy bazaar. I'm not sure they issue this. Can practice anywhere in India. NMC has a guideline that says you can practice anywhere, but even NMC has a restriction. If I'm going to go to another state and practice, I need to register with that state council. So that validity of that particular premium itself is invalid. So please mention your place of practice and get your policy document.
How do you see whether there is a misconception among doctors? Does indemnity cover negligence? In that case, I have done something deliberately illegal or something. Will it cover?
Actually, it covers the legal proceeding cost.
That's it.
It will cover, depending again on your policy, it may cover the legal proceeding cost, the cost of lawyers, cost of court. It will also probably cover the compensation, but that all depends on what your insurance
Actually, for
says.
one patient, we did inquire how to go about this indemnity part. They were very clear. If there is some litigation, the team, they have their own lawyers. They have their own legal team who will vet the entire case sheet and say this can be taken, not taken. They will outright reject if there is a negligence. So if there is no problem on your part, this is not your problem, then I think they will support you.
So that again depends on the agreement that you sign, the policy that you sign.
So how many of you have indemnity insurance for OP, outpatients? Okay, great. It's better all of us take it. It's very meager. As Prasanna mentioned, starts with some 1,500 and goes uphill. So you can choose one with a good cover. And there was a hue and cry 2 years before when Indian Penal Code was changed to BNS, especially from doctors' side. Doctors, lot of hue and cry in the social media that we are targeted. They've increased the punishment, 5 years imprisonment, and we are being treated like truck drivers, where immediately will be given sentence. So, and then it all dwindled down. So, how do you can explain legally? Do you think BNS is going to punish us more or something like that? Or
Actually, BNS has reduced the imprisonment period for doctors, but it includes it. Earlier it was imprisonment or fine. Now it is imprisonment and fine. And for doctors, it is 2 years where registered medical practitioners with carrying that state certificate, then it is valid. But at the same time, it specifically mentions doctors, and that I think has created this fear or this anxiety. Because earlier, if you went to the police station, it would be possible to say that this is not gross negligence or this is not criminal negligence. But now there is a specific section that says doctor and criminal negligence in the same page. So that creates the unnecessary anxiety and fear. And as regards whether it will happen immediately, in my opinion, most doctors will not suffer, they will be acquitted. But the harassment that they go through during that period, whether it is being asked to come for inquiry or police entering the premises, that I think is more harassment than required. That can be handled properly, it will actually be a reasonable outcome for
So this criminal negligence we need to define. So if not everything is a criminal negligence, and there is a process for the police also. See, we should be very clear. We cannot just allow a police to come and confiscate whatever we have documents. That is not, he has absolutely no authority to do that. If I'm not
No,
wrong.
it's exactly the same thing. The records belong to the patient. The police cannot say, I am doing inquiry, give me the file.
So we should be very clear, and Dr. Balaji will always say that we need to have a legal team in place, at least people who know to us, to actually come and help you out. These are the small things that we can do. But there is a process, we need to be very clear. Not everything is a medical negligence, criminal negligence, and immediately they cannot come and confiscate everything, seal your place, nothing of that sort cannot be done at all.
so just to give a perspective, civil negligence, for example, the way I understand, you give the wrong antibiotic for a person, or you give an antibiotic for which the patient has a documented anaphylaxis, that comes under civil. But you inadvertently steal the kidney and transplant, that comes under criminal negligence. That's quite extreme. I think a simple example for clinicians to understand. You do it with a criminal intent, that is completely different from you miss something unintentionally. You are doing that with a good intention, but something fired, something gone wrong.
Correct.
So that's a difference. So that's how the court views.
Yes,
Right.
one of the fears that people had was during emergencies, the doctor, whoever is available there, even though they may not be a specialist, they may take some steps, and that step might not lead to any outcome, good outcome. So will the doctor be held responsible? No, they will not be. But the interim period while the police is having their processes going on or their inquiries going on, that period has to be handled more effectively.
That's my chief used to say, all of us have a family doctor, all of us have a family auditor. Like that, we should have a family lawyer, or a hospital lawyer, or a clinic lawyer. You should know whom to call immediately. You are sitting in a peaceful clinic, suddenly 10 people barge in, come out with some allegations. You don't even know how to handle that. That looks miserable. So you should know at least a lawyer whom you can call. So it's better all of us have a lawyer, a family lawyer, a clinic lawyer, so that we will know what at least to do next. That's important.
Madam, I have a question for you,
Yes.
madam. This is non-allopathic doctors or somebody claiming themselves as doctors, claiming that, particularly in diabetology, they say that I have a cure for diabetes. What kind of negligence they commit?
They are criminal negligence only. If they are people who say, stop taking medicines and I will cure you without medicines, or people who say, I will give you naturopathy for bone cancer, such people are unlicensed practitioners.
There is no board for them to have a take action. Only the law can take action. But in medical doctors, they have NMC, medical council, the board is there to take. Then who has to complain? Who has to do all this?
It will generally be the patient only who has to complain, or some public interest.
Yeah. Sir, if you are actually, there is a rule in the government that says if you as a practitioner or anybody, you find out someone is a quack, you have to actually tell that, report it to your Joint Director of Health Services if it is a district, or to your Directorate of Medical or Rural Health Services if it is a city. So this is very clear. If we are the ones who are supposed to actually complain, it shouldn't be your name, but you can just tell them that so and so is. When I was in the service, when I was in the rural, there was one guy who came to me and asked, sir, நீங்க டாக்டரா? நான் டாக்டர். சார் நானும் டாக்டர் தான். அப்படியே நீ என்ன படிச்சிருக்கீங்க? நான் 8ஆம் கிளாஸ் தான் சார் படிச்சிருக்கேன். நான் பரம்பரை டாக்டர். இவன் வந்து எங்கிட்டயே கேக்குறான். அப்ப வந்து see, these are all the things that we cannot avoid, but then I faced him, but I couldn't do anything. It's practical.
In complementary medicine, there should be, even those who are practicing rational medicine like Ayush or whatever which is complementary, they cannot ask the patient to stop the allopathic drug. They cannot say, my drug will take care of everything, you stop this drug. That will amount to criminal negligence. They can say, you deal with your allopathic physician with regard to the allopathic medicine. In addition, I will do yoga, or I will give you Ayush, or I will give you Siddha, that is okay.
The vice versa is also true. We can also not prescribe any herbal preparation.
No, we cannot.
Please be very clear of that point. If
So
we have
that's
missed
where
it.
the integration of Ayush and MBBS comes. That's a separate topic which is picking up. So we had a separate discussion on that. So once that becomes legal, then that's allowed. So we can prescribe Ayush. I can also prescribe yoga therapy.
Sir, we are
No, it's
talking
already integrated.
right now, sir. Given point in time,
No,
I
the
don't think it
ministry
is
is going to start a integrated course in JIPMER next year. It's
There are some formulations in the market, and indigenous drugs, it has been popular for quite a number of years. Are we entitled to prescribe or not?
No, sir. No, because it is very clear in the Medical Code of Ethics and Etiquettes that it says that you are not supposed to prescribe such herbal preparations. It is not allopathic system. You are only a registered medical practitioner to practice allopathic system of medication and medicine, and not the other one. I cannot go prescribe. I can read a book on acupuncture and say you do this needling. That is not valid.
I am talking even that the MNCs, they are also got products with that the medicines of other systems.
MHC in the sense government run institutions.
No,
multinational companies.
Oh, MNC.
Pharma
Okay,
companies.
sorry.
Sir, until now, until today, allopathic practitioners, we cannot prescribe herbal or unproven medicines. But Ayush is getting integrated into MBBS officially, sir, sooner. Next year, it's going to get integrated by the Ministry of Health and Family Welfare. once new candidates are rolled out, for future MBBS graduates will be trained in Ayush as well as naturopathies. Maybe those candidates may have the license to prescribe. Until now, we don't have the license.
No.
Yes, we don't have that.
You're
Sir,
right.
one more thing. Sir, one patient comes with some Siddha medicine he has taken and he ends up in dialysis. He suddenly comes and ends up in dialysis. Can he sue that whoever is given that?
The way I look at it, I'll tell my view, the way I look at it, somebody takes a Siddha medicine, comes with a renal failure. By itself, it is not a negligence from the Siddha part. That's how I look at it. For example, I give gentamicin, patient gets an AKA. I give gentamicin with a good intent, he gets AKA. I give vancomycin, he gets AKA. I give some cancer chemotherapy, he gets a peripheral neuropathy, hair loss. So side effects are there for all the medicines. Like that, Siddha medicines may have side effects. If that Siddha medicine is a registered Ayush practitioner, if he is giving a permissible medicine, if that side effect is a complication, expected complication, I don't think that's a negligence. That's the way I look at it.
So practically
You're right.
அந்த சித்தா மெடிகேஷன் கொடுக்குற டாக்டர் தான் வந்து அந்த டாக்டர் கிட்ட சூ பண்ணுங்க, அவர்கிட்ட நிறைய காசு இருக்குன்னு அவர் தான் சொல்லி அனுப்புவார். நீங்க அவரை சூவே பண்ண முடியாது. ப்ராக்டிக்கலாக நான் பேசுகிறேன். Because I've seen in a lot of places where you go to any place where they're selling both these drugs, there'll be one patient who will come and ask that dispensing person, இந்த ட்ரக் வந்து இவர் கொடுத்துருக்காரு, இது சாப்பிடலாமா, இதெல்லாம் வேணாப்பா நீ இதை சாப்பிடு. அந்த டாக்டருக்கு ஒன்றுமே தெரியாது, நீ கோர்ட்டில் கேஸ் போட வேண்டியதானே அவனே சொல்லுவான். யூ கேன் ஆக்சுவலி அப்சர்வ் திஸ் இன் சச் டிஸ்பென்சிங் ஏரியாஸ் வேர் தேர் இஸ் அ கிராஸ் டாக் பிட்வீன் த டிஸ்பென்சிங் பர்சன் ஹூ இஸ் ஏபிள் டு டிஸ்பென்ஸ் போத் அலோபதிக் அண்ட் சித்தா. ஸோ எனக்கு தெரிஞ்ச அந்த த பேஷண்ட் வில் நெவர் சூ ஹிம், ஹி வில் சூ ஒன்லி யூ.
Okay. So last
practicality.
slide, Dr. Pushpa is upset because I am not the reason, because questions keep coming in. I am just moving the slides. Okay, this is the last question. So medical certificates, treatment certificates, leave. This is quite a controversy now, and a lot of litigations doctors are facing. So whether I can give a medical certificate or a leave certificate, how do you view that? Legally, madam, what is your point on?
So yes, by law, if you have seen the person, if you have verified the person, you have personally examined the person, and you are giving that medical condition that you have diagnosed, then yes, you can give the medical certificate. But if you are getting a request by phone or through your neighbor and so on, then no, then you cannot give any of these certificates.
There was one incident when I was in the service. There was one doctor, MD General Medicine, who had actually, in his clinic, there was one, a father had come and asked that his son is sick, so please give 2 days of certificate leave. எனக்கு லீவ் வேணும் சார், கொஞ்சம் கொடுங்க, பையன் ஸ்கூலில் சேர்த்துக்க மாட்டேங்கிறான். இவரும் வந்து கொடுத்துட்டார் சர்டிஃபிகேட்டை. The next day, police comes to him and says that, சார் நீங்கள் இந்த பையனுக்கு சர்டிஃபிகேட் கொடுத்தீங்களா? ஆமாம் நான் கொடுத்தேன். உடம்பு சரியில்லை, நீங்கள் பார்த்தீங்களா? இல்லை பார்க்கல சார். அந்த பையன் வந்து ஒரு க்ரைம் பண்ணியிருக்கான். நாங்கள் வந்து இஸ் a juvenile, அவனை வந்து நாங்கள் ரிமாண்ட் பண்ணுறதுக்காக நாங்கள் பிடிக்க போகிறோம். அவங்க அப்பா இந்த சர்டிஃபிகேட் காமிக்கிறாரு. உங்களை எனக்கு தெரியும், அதனால் நான் அந்த சர்டிஃபிகேட் வந்து உங்ககிட்ட கொடுக்குறேன், இனிமேல் பார்த்து கொடுக்காது, இந்த மாதிரி கொடுக்காதீங்கன்னு அவர் சொல்லிட்டு போனார். ஸோ திஸ் இஸ் ஒன் திங் தட் ஸ்ட்ரக் மீ வெரி ஹார்ட். as ma'am rightly said that you have to examine the patient, you have to arrive at a diagnosis, and then now there is a very strict format that has been a notification from the medical council itself that said you have to only give medical certificates in spells of 5 days. 5 days ஒரு ஸ்பெல் நீங்கள் அப்படி தான் கொடுக்கணும். ஐ எம் ஷுர் கவர்மெண்ட்டில் இருக்கிறவங்களுக்கு தெரியும் வாட் அ ஸ்பெல் அப்படிங்கிறது வந்து. பட் இன் ஜென்ரல் வந்து யூ ஷுட் கிவ் இட் ஃபார் மைனர் ட்ரீட்மெண்ட். give for 5 days and then review. You should also give the list of investigations or supporting documents that are there to give a valid medical certificate only. Please don't give medical certificate for diabetes hypertension treatment ங்கிறது வந்து மெடிக்கல் கவுன்சிலோட ரெகுலேஷன்லேயே அவங்க ஒரு கொடுத்துருக்காங்க. There is a very good thing that they have done, that they have explicitly mentioned how to give a certificate. You can just have a look about that.
Can a private doctor give a certificate for a government servant?
Yes, but the only problem is the government officer will not accept it, that's all.
And maybe under my treatment for fever,
We can, sir.
we can give.
We can give.
Why it will not be accepted?
The clerk there will not accept because he wants to get it from a government. Practicality. Yes, sir. Sir, board comes into play only after 2 to 3 spells, sir. Yes, sir, yes. They can if they don't like you. No, I completely agree, sir. What I am trying to tell is, if I don't like a particular person, I can refer him to the board any point in time. Yeah. But as per the rule of any government servant, first 2 spells they have to pay. The salary must be paid. You cannot hold a salary. If I am not wrong.
Another most important thing, antedated certificate should not be given.
Yes.
That is just now you narrated one incident that they have given a boy for fever, then he has committed. Likewise, it has happened. Because if you were given this antidote during that period, that fellow would have murdered some things.
Exactly, sir. As
That
ma'am
is the
rightly
most-
said, we have to see the patient. It should be
Yes.
at that given
At
point
that
in time.
point, yes.
I should I should arrive at a diagnosis today and give a certificate. I cannot predate or postdate it.
Yes.
Similarly, is a fitness certificate. I should give a fitness certificate. Only then the spell is getting completed.
Yes.
If there is no fitness certificate, then there is no completion of certificate.
Once. Sir, actually, I'm working in a government sector. Some person goes for a surgery for a like tertiary care center and gets a surgery done, and he is given a spell of leave from there. Then we can countersign it, or should we give a certificate from our end?
Ma'am, ESI, ma'am?
Sir.
ESI.
Illa sir. Atomic Energy Hospital, central government.
Okay.
Yeah.
Because this commonly we do face this. அது வந்து நீங்க உங்களோட சர்டிஃபிகேட் நீங்க கொடுத்தீங்கன்னா உங்க சர்டிஃபிகேட்டா தான் இருக்கணும்.
Yeah.
நான் கவுண்டர் சைன் பண்ண கிடையாது. நான் வந்து பிரின்சிபல் கிடையாது, அட்டஸ்டேஷன் போடல. You are giving a valid I think it's a legal document.
Yes.
Yeah. So it should be, you should give a separate certificate mentioning everything.
Correct. There is no counter signing. Your certificate. But in such a case, even though
They can, I think that is a process they are following in their institution.
Balaji.
that is enough. Yeah.
So we'll complete. I am ready. I have just completed, sir. My the thing is over.
So one question, sir. I'm working as a diabetologist in a tertiary care center, and we get foot infection patient, and when we are doing some surgery or something, sometimes the patient would have a wound in a foot, which will take a month's time. When we know that the patient is going to heal by slowly only, and he should not walk, so we give sometimes 1 month of bed rest and all. Is it okay?
If it is medically you can certify, like really you can vouch for it, I think you can do, but a maximum spell you can give for 6 weeks, ma'am. Medical council clearly states that you can give it in spells of 5 days, 5 days, 5 days. And then if it is a major procedure or there's an amputation or something that needs rehabilitation, something like that, you can give for up to 6 weeks. 6 weeks only it is valid. After that, then you have to recertify or then do whatever is necessary as per your regulation.
So like sometime patient coming from some other place. Recently I got a patient who is a police officer in Assam, and now he has come here. Now surgery is being done here, and then he is going back again. So but he need to have have bed rest for 1 month. So is it okay? So we can give that way.
Yeah, 6 weeks, you keep a timeline of 6 weeks, ma'am. You'll be safer.
Yeah.
But this police getting certificate is something I don't, because in the service we all the time get, right now I'm not in the service, but we always get this medical certificate from a police officer who wants to take leave. So I would
not
take,
just leave it.
No,
Surgery and all. being
I
done.
understand. So he wants to extend it.
Yeah.
That's the mentality they have. I say you stick to the 6 weeks and then later ask him to get it in a nearby practitioner, someone.
Thank you.
Any extension he can seek at his local place of residence.
Sir, regarding certain certificates like disability certificates, sir.
Madam, we are thankful to you, and you have cleared many doubts, because we do not know all along to whom we should ask. And Dr. Balaji has been kind enough, and Dr. Shanmugam also kind enough to have these wonderful sessions. Even small things we have got clarified. So once again, we thank on behalf of the organizing committee, both of you for enlightening the legal aspects in respect to our professions. Thank you very much, sir.
I thank
Balaji, though it is not mandatory.